it's very interesting what you have published with Gans and with us.
Good. Well, I'm happy to. Osama's been a big part of it, so we're happy to share what we're doing.
Yeah, I have seen one article, Osama name, but it is a very good read.
Yeah, we enjoy our work. So
yes.
Excellent. Thank you very, very much. And welcome to all our attendees, our distinguished speakers, our moderators as well. This is the third session of our Middle East Grand Rounds virtual sessions this year. So very honored to have each of you present here today. We already have 50 participants, so I'll probably give it another 2 or 3 minutes, and then we'll formally start. Excellent. So I see it's 6:03 p.m. Qatar time, 7:03 p.m. Dubai time, and early in the morning as well for Dr. Marlin. So it's very difficult finding a time that works for a global audience, but I think this suits most people around the world. So I think we're going to start. We already have over 60 participants, so we'll allow people to continue streaming in. But my name is Dr. Tasir Din. I'm the host for this session. I am pleased and have the honor of welcoming our distinguished speakers and attendees from all around the world. The last session we had, this is the third session of our Grand Rounds virtual network that had about 80 nationalities from around the world. So very happy to have people from all corners of the world join us. We'll also place in a YouTube link into our chat function. Edward, if you don't mind doing that, this just is for people to watch these sessions once again, and also share with people that missed out. And really the vision behind this, just before I hand over to our moderators, is to provide a platform, a free, virtual, easily accessible platform for our audience. This is done by the Middle East Academy of Otolaryngology and Tarabishi Healthcare. But really, we have international speakers from all around the world lined up for our year. And then in collaboration with that, we have a regional speaker that kind of hones in some of these points to ensure that some of the questions that are locally and regionally relevant are also answered. So we're very honored to have both Dr. Marlon Hansen, who is a world authority in cochlear implants, and Dr. Mondi Hamad, who's a internationally renowned cochlear implant expert based here in the Middle East, join us. I'd like to now hand over to Dr. Osama Tarabishi. Dr. Osama will be making the introductions and participating within the panel as well. It's very relevant for Dr. Osama to be making these introductions because he grew up here in the Middle East and now is currently finishing up his residency at the University of Iowa and is the incoming neurotology fellow at the University of Iowa under Dr. Marlon Hansen. So thank you for being that bridge, Dr. Sama. Welcome, and I'll hand over to you.
Thanks, Dr. Tassir. Yeah, very excited to be a part of this, and thanks for putting it all together. I'd like to first start with introducing our moderator, Dr. Mundi Hamad. He's a consultant otolaryngologist at the NMC Royal Medical Hospital, and he's co-director or co-founder of the Tarabishi Mundi Cochlear Implant Center. Dr. Mundi completed his training in otolaryngology and otology and neurotology in Germany at the Universities of Würzburg and Freiburg. And then after completion of his training, he went back home and joined the faculty at the University of Cairo, but ultimately in the late 2000s moved to the UAE to establish one of the first and largest cochlear implant programs in Al Mafraq Hospital. Dr. Mundi, I think, is widely regarded as a leader of the field of CI in the Middle East and is one of the most prolific CI surgeons in the Middle East. He's been instrumental in establishing cochlear implant programs both in his home country of Egypt, but also in the UAE and Sudan, and has himself placed upwards of 1,000 devices. And in addition to his vast experience with cochlear implantation, he has a thriving practice that sort of encompasses the care of all aspects of otology and neurotology. So we're very thrilled to have him as our moderator today. And then our speaker today is Dr. Marlon Hansen. He is professor and chair of the Department of Otolaryngology at the University of Iowa. He underwent medical school training at the University of Chicago and completed residency at the University of Iowa before going on to do a fellowship at the House Ear Clinic in otology and neurotology. He's since returned and has been on faculty at the University of Iowa in otology and neurotology. Dr. Hansen really is an extremely accomplished clinician scientist. He runs a lab that primarily focuses on investigating tissue responses to cochlear implantation and better understanding the cochlear foreign body response and try and figure out ways to mitigate trauma and mitigate inflammation and improve hearing preservation and device and cochlear implant outcomes. He's also very active in clinical research. He's a co-director of the Institute of Clinical and Translational Science at the University of Iowa, and he's a co-investigator in the University of Iowa Cochlear Implant Research Center grant. And he's very interested in looking at ways to enhance hearing preservation and cochlear implantation with drug elution, robotics, and electrophysiology, and tracking those things intraoperatively. In addition to all that, he's got an extremely busy clinical practice and does all aspects of otology, neurotology, and skull-based surgery. I feel very fortunate to have him as a mentor, and he's mentored countless trainees at various levels throughout his career. So we're very excited to have him today talking to us about hearing preservation, cochlear implantation. So with that, I think I'll hand it over to him.
Thank you very much. It's just a treat to be with. Thank you, Dr. Mundi, Osama, Tassir. It's great to see you, and I'm very honored to be part of this and send my best wishes to your region that things can go well. So with that, I'll try and see if I can share my screen here. Hopefully you can see that. Okay. So yeah, I'm here at the University of Iowa, and we've been very fortunate to have Osama be part of a program. A lot of what I talk about will be work that he's participated in. I'm a couple of disclosures. I'm a co-founder and chief medical officer for Out of Motion and Zwicote Materials Innovation, and we have funding from NIH, NSF, Department of Defense, American Otologic Society, American Neuro-Otologic Society, and a few other things. And really what I probably should emphasize in the outgo is I'm one of many, many, many people who get involved in hearing research and cochlear implant research at the University of Iowa. the list is enormous. Bruce Gantz has kind of been at the helm of that for many years. But there's also many other people from within the university system as well as other institutions that get involved. I'll highlight a lot of work at the end that we're doing with some chemical engineering people with Alan Guyman. So to start, I want to just reiterate a concept that I think is now becoming at least recognized, if not appreciated, which is that when patients have low frequency acoustic hearing that's preserved and useful, they do much better with their implants than they do with just standard electrical stimulation to the cochlea. And this has been shown now in many ways. These are some of the ways that happens. So your ability to understand words in quiet, just simple word recognition scores, is up by about 20%. More importantly, though, speech understanding and noise, and that's given by example of this graph down here, where we're looking at how much what the signal to noise ratio is for people to be able to hear with background babbly noise. Normal hearing, they can get down to about a -20. Standard implant patients, it has to be up to like a +10. But in the middle here in the red, you can see that if you preserve that low frequency acoustic hearing, now these patients with electrical hearing do far better. With electric plus acoustic hearing do far better than those that only have electrical stimulation of their cochlea. They're able to, and their ability to perform on that task is directly correlated to how much residual hearing they have. If they lose hearing, then they tend to be up here. If we preserve the hearing, then they tend to even be further down here. So there's a direct correlation with your performance on hearing and background noise and how much residual acoustic hearing you have. And that's because, sound has a temporal fine structure to it, has amplitude modulation, frequency modulation that's really important for things such as the quality of sound, localization of sound, speech understanding, noise. An electrical stimulation really can't recapitulate that in any meaningful way. So, having said that, I think it's a little misguided to think that the only reason to save structures or function in the cochlea is to preserve that acoustic hearing, because a lot of the ears that we treat don't necessarily have a sufficient amount of residual acoustic hearing to benefit from that, although an increasing number do. Yet every ear has function within it, whether it's sensory function, meaning intact hair cells, or whether you're just talking about neural elements and their ability to respond to sound. And we need to be able to preserve the structure and the function of the cochlea as much as possible, that somehow we could place an electrode array within the scala tympani and there be no trace that something was placed within that ear. That's kind of the goal. And so I want to talk about 3 different technologies that are on different phases of development that might help us in that. So the first is robotics. Robotics are now available in the US and Europe, and they're becoming more and more commonly used. And so we'll talk about the robotic system that was developed here out of the University of Iowa and our experience with that. Then something that is now still being used in patients, but is still in a developmental stage, is drug-eluting electrode arrays, and I'll show you some of the data around those. And then finally, I'll talk about something that we're working on that might be helpful, beneficial down the road for the future. So emerging technologies, and then going on to something that's still yet to be fully realized. So the notion of robotics with cochlear implantation, and when I say robotic cochlear implantation, we really mean robotic assisted. And I also mean that it is the placement of the electrode array within the cochlea, not access to the cochlea. So there are other systems that have been developed as sort of cochlear access systems, but they really weren't initially conceived of as cochlear implantation systems. But we're more interested in using the ability of mechanical devices to provide a more steady and slow insertion into the cochlea. So this is an unroofed cochlea. This is an example of an electrode array being placed manually into the cochlea. Now you notice there's a lot of micro movement of that electrode array as it goes into the cochlea. Those micro movements generate force and generate friction and generate some trauma. On the right-hand side, you can see what happens if you have a robotic assisted where you take control of the speed, you make it not only slower, but you make it much more steady. This will reduce insertion forces, reduce the spikes with pressure spikes within the cochlea, and reduces trauma within the cochlea. And that's been shown in lots of different ways. This is just one example of tracings that come out of our lab, where if you look at in the upper panel, there's 4 different electrode arrays. These are force measurements over time. And you can see as a human hand is doing it, there's a lot of jerkiness to it. And there's also higher forces. Whereas in the one below, the same electrode arrays are now being inserted with a micromechanical robotic assisted tool. And you can see how much that reduces not only the overall forces that are generated, but dramatically shifts kind of the jerkiness that are just inherent limitations of human kinetics. Like I alluded to before, not only is it the forces that matter, but the cochlea is a closed space. And as you introduce more volume in there, that generates, especially if you do it in sudden kind of jerky things, that introduces pressure spikes within the cochlea that are equivalent of loud explosions. And so if you can reduce the jerkiness and the speed at which you're doing that, then you can dramatically reduce the amount of pressure events that happen within the cochlea. And that's been shown with our device as well as with other devices that have been developed. And so these are some of the things that are out there. The HERO system developed out of Bern, Switzerland with Casanation. It's distributed by MEDEL. It's really a cochlear access system and would still require manual implantation, although now they're integrating it with the MEOTO drive, which is their latest version. The Robotal system is distributed by Colin Medical. It's a French system. It's a large thing that sits at the side of the patient. It can be used both for stapedectomies and for cochlear implants. And again, gives you this micromechanical control. It adds about 30 minutes to the OR time. The HERO system, again, is a very different type of a system and adds several hours to the OR. The IOTASoft system, which is what we use at Iowa and was developed out of the University of Iowa, was really a small platform disposable device that enables the mechanical control that we all want to achieve, but doesn't really take over the rest of the operative environment. And then finally, MEOTO drive is new. It's available in Europe, and I think they're doing their first studies in the U.S. now, but it's still under study. It's mounted to the bedside, and again allows, similar to the IOTASoft, is trying to do this micromechanical control of the electrode array insertion. So this is our system where you have a holder that houses a unit, and you screw this, you secure it to the patient's skull with these little screws up on the tegmen. And then this is the micromechanical drive unit, and then this is a head that the electrode array comes through this and then fed into the cochlea. And then this is kind of our control console with a foot pedal, blue for going forward, yellow for reversing, and then the surgeon can control the speed at which they want that electrode array to advance or withdraw. And then this is a flexible neck so that you can kind of align the trajectory with however you want. There's a little alignment tool that gets centered in the middle of that drive head. This was a study that we did early on. This 16 surgeons where they were randomized to electrode array and randomized to which ear they were going to put it in, and then whether they were going to put it in robotically or manually, and then they would do the opposite ear the other way using fresh frozen human cadavers. And then we use this 3D X-radia to provide an analysis of how much trauma happens in the cochlea. Are able to show that in a cadaver model, not only are forces reduced, not only are pressure events reduced, but trauma events like scalar translocations or fracture of the osteospiral lamina are significantly reduced when you have a robotic device. So we did, this goes back to the middle of COVID when we did our FDA confirmatory clinical study. You can see that this is a manual array being inserted in the OR. And then on the right, you can see a robotic assisted. You kind of get a sense of the differences of how the insertion goes, whether it's manual or robotically controlled, where it's a very slow, steady insertion. Since you don't have to use your hand to drive the array forward, you can also have a second hand available during the surgery to do suctioning or whatever you might do. And the amount of time, it on average now, it probably adds about 10 minutes to the operative experience. And that's been pretty consistent across. I think this is now in 35 to 40 centers in the US. So if we look at our hearing preservation results, so again, I don't think robotics should only be restricted to people that have residual hearing. I think every cochlea deserves as little trauma as possible when you put the electrode array in. There's ample data to support the notion that even in deaf ears or profoundly deaf ears, trauma leads to severe inflammation, neoossification, neural loss, and decreased performance with the electrode array. So, but having said that, the easiest way to determine whether we're having an impact or not with robotics is to do it in people that have functional hearing, because that's such an easy measure to take of how atraumatic we might have been with the surgery. So this is a comparison of patients that were implanted manually, and then another series of similar patients implanted robotically, and they're implanted. The only difference is these are all MED-EL flex electrode arrays. The only difference is they were a little bit longer of arrays in the robotic assisted than they were in the manual, but otherwise they're very comparable. And you can see that initially they were similar, a little bit better for the robotics, but over time, the patients who had the robotic assisted had much stabler. So by the end of 1 year, with manual, we had about 63% of our patients had hearing, continued to have functional hearing preservation, whereas 85% of those that were done robotically had continue to have functional residual hearing. And then we looked at it with maybe even a more strict criteria where we said, after the initial, whenever your best hearing was after surgery, whatever level that was, did you lose any additional hearing? Or at least did you lose more than 10 decibels over the subsequent year? Because a lot of these patients will, even if you preserve their hearing initially, they may have 10, 15 decibel drop progressively at 3 to 6 months, or maybe even out to 12 months. So if we look at the stability of the hearing and the ability to prevent this delayed hearing loss, that's where the robotic seems to have such a dramatic impact, where the hearing levels, when it's done robotically, and this is both for MED-EL and advanced bionic electrode arrays, are quite stable, whereas with manual insertion, we see these patients, even if we save their hearing, a percentage of them will continue to have ongoing hearing loss. And that's kind of illustrated here, where if you look at both at 1 year, it's probably better to look at it over here, where you can compare the number of patients that had preserved hearing with manual insertion, which was 38, but 22 had progressive hearing loss, where only 2 of 29 had this progressive hearing loss in the robotic assisted. So again, that kind of bears out the notion that this reduction in force, reduction in intercochlear pressures, reduction in trauma does lead to improved patient functional outcomes. One of the other things that we commonly do at Iowa, and I think in many centers in the US, is we want to sort of have some ideas, both preoperative planning. We want to have some intraoperative monitoring that we're doing. And then sometimes there's even some postoperative things that we can do to check electrode array position and things like that. So we have all these systems. We have imaging-based systems that we can do preoperative planning with. We have intraoperative monitoring systems. But so far, those are all done in isolation. They're not integrated one with another. And so we've been working on that. We actually have a presentation here at our COSM meeting this next month showing the integration of the robotics with an ECOG system. But what I'll show you here today is not integrated, but it still is, you can kind of see how we use them together. One of the reasons to integrate, it would be similar to the notion of having automatic braking in your car. So if you can integrate ECOG with robotics, first of all, you're going very slow robotically, so your ECOG signals are more stable and easier to average across. And if there's a change in something and you have it integrated with the ECOG, if there's a drop in the ECOG response, you can automatically stop the electrode array advancing. And so if you do that, it would only advance about 1 micron. Whereas if you don't have these systems integrated and you're doing it manual insertion, you're going to travel at least 1 millimeter from the time that there's a signal that there might be a problem to when you actually can stop that. And in the cochlea, 1 millimeter is a mile. So we think this makes real meaningful difference. So this is an example of a patient who had this kind of audiogram. We were intending to implant the right ear. Subsequently, after the right ear was implanted, the left ear actually looked exactly like the right ear did over time. And so he ended up with bilateral implantations. And we do that robotically, and then we do it with ECOG monitoring. One of the ways robotic assists is it enables us, it gives us better ability to do this multi-frequency ECOG. So we're not just doing a 500 hertz tones. We're usually doing 250, 500, 750, and sometimes even 1,000 hertz. And this shows you kind of why multi-frequency ECOG is so helpful. So this is over time. So you can think of this time scale on the bottom axis as how deep the electrode array is being positioned into the cochlea. And when you start off in the base and there's not much hearing, you have these low amplitude responses. And then as you move the electrode array and you're recording from the electrode that's at the apex or the tip of your array, as you move that closer and closer to the region of the cochlea that's being excited by sound, you should see a growth in those responses. And if you're doing it across multiple frequencies, often what happens is if you're at the 500 hertz, all of a sudden you might see a drop in 500 hertz, and you need to decide, was that drop a meaningful drop, or is that because the electrode array has now passed the region of the cochlea that gives you this 500 hertz response? And so then, as you can see over on the right-hand side, we would look at this and we see this drop in 500 hertz, but we see that the 250 response continues to grow, and we would view that as an atraumatic event because the electrode is just past the 500 hertz. Whereas over on the left, we would view this as a potentially traumatic event because we see a drop in both the 250 and the 500 hertz frequency. So these would be really difficult to do if you're doing this manually. It takes time to average. It takes time for the audiologist to give you these responses. So doing it robotically is really helpful. And that's what we did with this patient. This is actually the right ear hearing. This is the left ear hearing eventually. And these are the results out, over a year. The right ear had very nicely preserved very nicely preserved hearing. The left ear had the same. And you can see that in noise, they're doing extremely well. In a +5 signal to noise ratio, which is really a difficult task, getting 85% word correct, which is pretty amazing. So now move away from just the placement of the electrode array surgically to what we're doing when we're putting something in the cochlea. So cochlear implants are composed of both silicone and platinum. And when we put that into the cochlea, we can cause trauma, but also the body recognizes those materials as a foreign body and mounts an immune response to that. And it's been well characterized a lot of ways. So every human, every animal that you place an electrode array in, you get this fibrotic capsule around it that can have pretty dense initially and then some looser inflammation around it. These can get quite severe where you have neoossification that happens around the electrode array. And there's often these foreign body cells that develop around them. And this process is largely driven by the surface properties of the materials. So when we place a biomaterial in the body, within a few seconds, there'll be absorption of proteins onto the surface of that material. That will enable inflammatory-like cells, immune-like cells like macrophages to adhere to the surface of the material. And then that will drive this foreign body response where you now recruit myofibroblasts, get this collagen deposition to kind of wall off this foreign body. But it's driven mostly by the surface properties of the material that you're placing in there. Maybe one other concept to look at is what we would like to know is how much of this is happening inside the cochlea, how much fibrosis, how much tissue is growing inside the cochlea. We can't see that. So what we do is we use measures of electrode impedance as surrogates for markers of that inflammation. And I'll show a way this is commonly done is to look in monopolar state and to desegregate the impedance measures from a polarization impedance, which is the second phase, the second time phase, which has more to do with the direct interface with the electrode and electrolyte versus this initial access resistance, which is felt to be a better marker of the fibrosis and neoossification. So this is kind of the commonly way that it might be done, where we use impedance as a biomarker for what's happening to the tissue inside the tissue response inside the cochlea. And this is a group of patients that initially had good hearing preservation, and then over time, some of them lost their hearing. And those that lost their hearing had this rise in their access resistance over time, but no change in their polarization impedances, suggestive that this delayed hearing loss that's happening is related to this fibrotic or inflammatory response that's happening around the electrode array. And this is one of those patients where initially had very well preserved low frequency hearing, and then 4 months after surgery lost all of his hearing, and then died 7 years later. And we got his temporal bones, and the group at Mass Eye and Ear, where Osama used to work before we coaxed him to come to Iowa, did the histopathology of that. And again, what they noticed was in the area of the ear where there was the implant, severe fibrosis throughout not just the scala tympani, but extended into the scala vestibuli. There was hydrops. Up in the apex of the cochlea, where there was no biomaterials, the cochlear structures were largely preserved. And so we've been thinking about how does the ear respond to these biomaterials a lot. One of the things that I think has been a notion that's been out there for a long time is that the cochlea was immunoprivileged. And we don't longer believe that. And a lot of times people said, well, there's no lymphatics within the cochlea. That was one of the reasons for the basis of saying that there wasn't an active or an adaptive immune response. But using mice, and then the nice thing about mice is you can control their genetics and you can have reporters and other things like that. So this is just to show you some work that's been done in the lab looking at lymphatic structures within the cochlea, and there is a very rich lymphatic network throughout the cochlea. And maybe I can just show you this movie of one of the stainings of that. And I want to highlight that the lining of like the scala tympani is just filled with this lymphatic network. And so when we're putting the electrode array in and we're scraping against the edge of these tissues, we're abrading these lymphatics. And that may be part of what helps initiate these foreign body responses. And so we've used these mice to look at this response quite a bit. And we have this notion now that what happens around an electrode array is you get this ectopic lymphoid structure, almost like a lymph node that develops within the scala tympani. And so this is a reporter mouse where blood vessels will fluoresce green and lymphatic vessels will fluoresce red. This is where the electrode array would sit. And you can see that you have both neovascularization and neolymphogenesis happening around the electrode array. These are markers for different types of immune cells, and we won't go into all of them, but there's macrophages, there's lymphocytes, there's dendritic cells. They all express MHC2, which I don't show you here. We see these both immunologically if we stain for them, if we have reporters for them, and if we do single-cell RNA-seq. We get the same kind of picture of this very enriched immune environment, multicellular activated immune cells around the electrode array. This is just more of the lymphogenesis that we see happening around it. And so then we move to a different mouse that now has markers for macrophages. All the macrophages in the ear will fluoresce green. The neurons will fluoresce yellow. And we start putting cochlear implants into these ears. And we do it, and we have cochlear implants that are now doped with dexamethasone, similar to the ones we're using in patients. And this is just to show you, maybe we can go all the way down to the bottom, L, M, and N, and you can see that in a standard cochlear implant, the scala tympani fills with soft tissue around the implant array. Believe it or not, in M, that is a cochlea that's been implanted for 112 days with an implant, and we don't see hardly any immune response around the array or even yet throughout any part of the cochlea. Most of the macrophages still remain suppressed throughout the entire cochlea, whereas the contralateral ear looks pretty typical. So, and now we have this out to a year where the dexamethasone elution is suppressing this pretty vigorous immune response to the electrode array. And that's, we can quantify that, show you that it does happen. We look at this in other ways. We look at smooth muscle actin, which is a marker of myofibroblasts or fibrosis, and that sits on the edges of this immune response and is dramatically reduced again by having dexamethasone-eluting electrode arrays. So now this is doing the same thing, but now in human patients. So we have about 30 patients that have been implanted with dexamethasone-eluting electrode arrays, as well as some controls. And this is now looking, instead of looking at access and polarization and monopolar measures of impedance, this is looking at 4-point impedance where we're actually measuring the impedance across a 4-electrode pair, where the outside two have the stimulus, the inside records the impedance. And that bipolar type impedance is much more indicative in our hands of, or much more sensitive to tissue changes. And you can see that over time, where the green are the electrodes. Each one of these represents a patient. This would be from base to apex across the array. And these are these bipolar impedances. You can see when they start off the same, and then over time, the black ones, which are our controlled standard ears, you can see the growth of this tissue response. It starts in the base, and then this is growing over time. So initial activation, 1 month, 3 months, 6 months. And that's kind of highlighted here, where you see across the array over time, starting at the base, and then moving over time. So as you have time and you move towards the base, you get this dramatic rise in these bipolar impedances, which correlates, we think, with the fibrotic tissue response. And the dexamethasone completely suppresses that, even out to a year. This one patient that started off high in dexamethasone actually had a silicone allergy. And that patient, their impedances, although they started high, the dexamethasone even suppressed those by 3 months or by 1 month. So if we look at hearing preservation, I can tell you the results are not. First of all, these were patients we weren't really doing as a hearing preservation experiment, but we looked at their thresholds. And there seems to be no real difference in their initial threshold shifts, whether they have DEX or whether they have controls. Maybe the DEX have a little bit more stable, but not that different of hearing outcomes, DEX versus controls. And I can tell you that there's some other things that we're not quite 100% sold on whether DEX is going to be as dramatic and as impactful as what was shown you with impedance data. So I think the story is yet to be told of what the clinical benefits of the dexamethasone might be, but we're excited to keep working on it. And now, just for the last couple of minutes, I want to talk about a different concept, again, of ways of addressing this foreign body response. So as I mentioned earlier, this foreign body response is driven by the body's reaction to the surface of the material that you're putting in. So if you can somehow change the surface of the material, you could perhaps mitigate that. And so what we do is we've developed this coating. Think of it like a biological Teflon that you might put on your pan so the eggs wouldn't stick. So you put this coating on there that doesn't allow cells or proteins to stick, and then see what kind of impact. And these materials that we're coating it with are Zwitter ionic, and I don't want to go into all the chemistry to why that works so well, but it works extremely well. And we have very precise control of it. It's a light-driven process where in a single step we can both covalently graft the coating to the surface of the material, as well as form the thin film that happens. And by controlling where the light shines, you can see how effective it is. So here is a protein adhesion assay where the areas that are green show you the green protein, and that's where the light wasn't shined, and the areas that are black are where the light was shined, the coating would exist. And so no proteins or no cells, these are fibroblasts, stick to the region of where there's a coating. And we can control that at a micro scale by controlling light. This is what a coated electrode array would look like. It's just this one, we stain it blue so that you can see it, but it's a clear stain. We can control the thickness just by controlling the initial intensity of how much light we use and the duration of how long we do it. So we can have thicknesses that go from about 10 microns all the way up to close to 60 or 70 microns. Or if we go even with a higher intensity light, we can go up to over 100 micron thickness in our coatings. And this is an example of how these coatings prevent the foreign body response. So this is a piece of silastic that's placed in an animal for a year. And you can see the foreign body response that would normally develop to an uncoated region. And then this is a coated region. You can see that it almost completely eliminates this fibrotic inflammatory response if you're looking out over here. And that happens to when we do it in cochlear implant arrays, we see that dramatic reduction in fibrosis, even out to a year. The other thing it does is it holds a water layer, so it makes things really slick, just like if you have a football field and you put water on it. The players can now slide. So if you have this coating, it reduces the friction relative to PDMS by 95%, and that reduces the forces of insertion by about 50%. So we've put these implants in sheep and measured impedance. And one of the things that we noticed is that not only does it reduce the impedance long term, but it actually has an immediate impact on current flow from the electrode arrays. So it reduces the resistance to current flow by 50% just by having the coating on there. And we think we understand how that works. It prevents the ions from pairing up, and so it enhances, it creates these little microchannels for current to flow through or for ions to move. And we see that across, even out to 6 months in sheep, we see this 50% reduction in impedance. And then this is just to show you some data that it reduces the foreign body response in red. This is a standard implant in a sheep cochlea. This is a coated implant in a sheep cochlea. So just to quickly summarize, it's important to preserve structure and function in all cochlea, not just for hearing preservation, but for the function of the cochlea long term. And robotics can really help with that. I think it reduces some of the inherent limitations that we have as humans in being able to control an electrode array insertion. It allows integration with ECOG and other things, and at least our data, as well as many others now, are showing the clinical benefits of this. Dexamethasone eluting arrays are now on the verge, I think, of being FDA approved. They do a good job of reducing inflammation, fibrosis, and electrode impedance. But I'm not sure yet how much clinical benefit we'll see from it. That's yet to be worked out. And then finally, the far future is using these Witteronic coatings that I think can reduce the body's foreign body response, reduce friction, and also enhance current flow from the impedance, so that enables us to do some of the more difficult programming strategies with electrical stimulation that we've never been able to achieve yet, like tripolar stimulation or other things like that. So with that, I'll conclude and thank many people who have been behind this work, including Osama Terabici.
Thank you very much, Dr. Hansen, for this very, very interesting talk and the futuristic talk about the cochlear implant. But as you know, for this robotic surgery, still early for our area to get it and to work in it. So I don't think that it will be like the standard in the coming years in most of the clinic. This is why I would like to ask you about your advice and your technique, how to preserve the structure. I'm not talking about the hearing because I'm more about structure preservation, even in profound hearing loss, as you mentioned. So your technique in Iowa pre-robotic era. So what are do? So like electrode choice, cochleostomy. What is the best chance to preserve the structure?
Yeah, I think those are, obviously these are issues we grappled with well before robotics, but so I think there's a lot of data to suggest that if you can use a round window, that's better. You can avoid drilling, that's probably better. For us, I think that means that you have to do a really good exposure around window. You have to completely take the face off the niche and have it nicely presented to you. Even though the data don't support that local DEX makes a long-term difference. I still use it because I like it to hydrate. So what I do is I have, once you have the round window well exposed, I use a 27 gauge needle attached to a 1 cc syringe with dexamethasone to kind of puncture the round window membrane. And then I pick it open, and then I use that to just gently create a hydration layer so the perilymph doesn't kind of leak back out. And then I open the round window. And I used to open the round window kind of minimally. And now I'm convinced that you need it open pretty good to allow egress of the perilymph as you're inserting the electrode array so that you don't generate as big of pressure spikes. And then if there's residual hearing, it's nice to have ECOG. If not, as slow and as steady as you can reasonably do it. Releasing the electrode array, and everybody who does it, this is something that robotics is not perfectly solved. Sometimes the release of the array, it kind of has a coil to it, and it'll generate more force than it did putting it in. And so have a plan. What I like to do if I'm doing it robotically is I like to pack the electrode array around it before I even let go of it so that it doesn't, those forces don't transmit into the cochlea. I think those are, in terms of which arrays to use, that's an interesting question. I think placement of the electrode array, the more flexible lateral wall arrays tend to be less initially traumatic because I think using the sheath, the problem with the perimodiolar are, one, if they have a stylet, they're really stiff and difficult. Those are pretty traumatic in my experience. The sheath itself, I have to, more often than not, I have to drill or not drill, but extend the round window niche just about 0.2 millimeters to get the best trajectory of that sheath. And then introducing the sheath, I think, is more the problem. The perimodiolar electrode array, the slim perimodiolar that Cochlear makes, I think sits in a really nice position. And in that way is less traumatic. It's not up under the basilar membrane. I think in some ways it's less traumatic, but getting it in there is a little more traumatic. So on the balance, I tend to favor lateral wall arrays if I'm really trying to save hearing. And I like perimodiolar long term for where they sit. So I don't know. Yeah.
Okay, for the important point that you have mentioned about the fixation of the electrode after insertion, because this is a very critical moment that you can lose the
Yeah.
structure after it. So what I am personally do is that I like drill a small groove in the bony groove in the lower part of the posterior tympanotomy.
Yeah.
For cochlear, I use the point 0.5 drill. For advanced bionic, I use the 0.6. For mid-L, I use the 1 millimeter.
Mm.
And then soon after insertion, I just slide the electrode in this bony groove. Then it will be fixed. The problem of introducing the tissue and fix the electrode before coiling, you have the minimal chance that the electrode will pop out or will move without noticing it. It happened with me one time. So
Yeah.
what I'm doing is fixing the electrode in the bony groove first, coil the electrode, and then pack around the electrode.
Yeah. No, I think, and that's, I know that's German. That's a very,
Yes.
yeah, yeah. And I like, we struggle with, we have sutures that we use and tie
Yeah.
and do that before we take it off the robot and stuff. There's a lot of things, but your point is very valid that you got to have an exit strategy. It's not just getting in there, but you have to have an exit strategy. Yeah.
And regarding the length of the electrode, so if you have a very good hearing in the low frequency up to 250 or 500, so I know that the Iowa school, they just started with this hybrid 10 millimeter electrode. But what is your strategy
Yeah.
now regarding the length? Are you still using that, or are you using normal electrode, and how long you introduce it in the cochlea?
Yeah, good question. So, we don't have any hybrid electrodes anymore. So we use standard length electrodes. I mean, ideally, what would be really nice is to have. I think there's several variables that are going on here. One is how big the volume of the scala tympani is. If you have a cochlea with a large volume scala tympani, I'm not talking about the cochlear duct length. I'm talking about the volume of the scala tympani. If you but that varies across the cochlea. It can change a little bit. The bigger that volume is, the better we're going to be at saving hearing. And there's data to show that cochlear volume makes a big difference on how well we save hearing. And that also then tells you maybe how much material you might be able to put into the cochlea. So that's one thing to consider. What we typically do is we make the decision based off of electrocochleography. So we'll be advancing electrocochleography, and if we see a drop, pull back a little bit, and then we sort of look at the hearing test, look at the age of the patient, and have to make a decision like, do we want to put it in all the way, or do we want to leave one or two electrodes out and preserve the low frequency hearing better? And we tend to favor preserving low frequency hearing with not a half insertion, but if there's 22 electrodes and we leave two out, we don't feel too bad about that. If it's a 16 array, we don't feel bad about, or a 12 lead array, we don't feel bad about leaving one out, if we preserve low frequency hearing.
Okay. And in such case, if the patient lose his hearing in the future after 2 or 3 years, you just reopen and
Yeah,
reinsert the electrode,
that's a
or what
really
is?
good question. So
Yeah.
that goes back to the whole idea behind the robotics that we did was actually for that problem, not for, we actually have a device where we can use it transcutaneously to advance the electrode after it's been placed years later if they lose hearing. So that was the original robotics idea that we had. It's not available, of course, but so what do we do practically? Yeah, if they're not, most patients, even if they lose their hearing, they still perform pretty well. And if they're doing okay, if they're doing what we would standardly expect someone with electrical hearing only to do, then we wouldn't advance it. If they're doing poorly, then we revise it. And we first try and revise by just advancing the array that's in there. And every once in a while, you have to put in a new array. But yeah, challenging problems.
Okay. So are you using the electrocochleography in each patient with
Just for
residual
hearing
or hearing
preservation.
preservation? Yes.
Yeah,
Yes. Yes.
not standard implants.
Yes. 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 Sure. Sure. But the same structure preservation technique in a standard cochlear implant. I think. I mean,
Yeah, we
if you have
still,
a prefer-
still preserve as much as you possibly can. We just don't monitor it with electrocochleography.
Yeah.
But we'll do robotics if it's a lateral wall array, we'll do robotics even if it's profound hearing loss. Yeah.
Okay. So I have a question here. There is one of the candidate is asking about what is the presenter opinion if there is any clear-cut difference in hearing between perimodiolar and lateral wall insertion using conventional or advanced hearing preservation technique.
Yeah,
So
it's a good
in your
question.
experience, yeah.
The data are there is no difference. Now, could it be that there is a difference and our measurements aren't quite subtle enough to detect it? But the data are when people have done this, and there's even been a few randomized studies are well controlled and not done by industry, but done by the investigator initiated studies, those show that there's no difference between perimodiolar and lateral wall. I think for hearing preservation, it's a tricky question because in our hands, if we preserve hearing with a perimodiolar, it really stays good quite long. And we do that a lot in children, but you don't have the flexibility that you do like with a lateral wall array where you can be doing electrocochleography and going slowly. I mean, to deploy a slim perimodiolar, you need to do it smoothly, but you're not going to be doing it while as you're monitoring things. So, yeah.
Yeah, I did a lot of perimodular electrode, and my experience, as you have mentioned, that if the angle of the round window is nice and good, I mean it's facing you, so it's easy. But the problem that if the round window is tilted, it's more vertical, so the angle is more far from you, then there is a risk of folding of the
Yeah,
electrode, tip
tip
folding.
fold over and yeah.
Then you have to drill more, and this drilling is add more trauma.
Yeah.
And I think it was a time when I asked to have both implants and decide intraoperatively according to the anatomy. And if the round window is nice and I can see most of it and is facing me, I don't need any drill, I can go with the perimodular electrode. Otherwise, I prefer the lateral wall electrode in
Yeah.
order to avoid drilling.
Yes.
Okay, we have here a second question. Thank you for joining us. No, sorry. He is asking if the robot can be used only in posterior tympanotomy, not in other approaches. So the conventional approach.
I mean, it hasn't been tried in other approaches. So, I mean, it has been used if you're doing like a subtotal petrosectomy, but if you're talking about like a trans canal or something like it would be difficult to configure it, but it might work. I don't know. I haven't tried it. I don't know if
Okay.
anyone has. Yeah.
Okay. So I think we are it's a time now to conclude the because it's almost 1 hour. So Osama, do you want to conclude the
Yeah, sure. No, I just think thanks, Dr. Hansen, for joining us. It was a great talk and really appreciate it. And thanks, Dr. Mundi, for moderating. I think like Dr. Tasir Dean said that this will be uploaded online for people to go back to if they want to take a look at it. But yeah, I think we could probably conclude with that. Thank you, everyone.
Thank you. Good to see everybody.
Thank you, Dr. Han. Thank you. Bye.